give you a minute to share your screen, and I will unspotlight myself and leave it to you.
Yeah, absolutely. Well, and that does lead me into what we're going to cover a little bit today with this biopsychosocial impact. Obviously, I'm coming in on the biology side of things. We'll touch a little bit about what it means for the rest of the kind of mindfulness and again some of those sociocultural norms, because I think that happens a lot for folks when we're talking about sex and aging, and that there really isn't an expiration date. And that's what Rebecca and I had talked about early on. And unfortunately, we do see that with the noise and the background within our community. So hoping to break down a lot of these barriers as well. So you can see I have like this alphabet soup behind my name also, and just to give a little context of what these mean. So I'm a certified PA. Again, we talked about being a nationally certified sex counselor and educator. I'm also a nationally certified menopause practitioner. I do a lot with ISWISH, which is the International Society for the Study of Women's Sexual Health. And I'm also a HAES provider, which is a health at every size. So just to, like I said, kind of let's jump into the meat and potatoes of this. So welcome. We already talked a little bit about introductions, and I am just so excited to be here and to just, again, have the tip of the iceberg, just a snapshot of what this is going to be. I hope that I really leave you with a curiosity and a lot more questioning, and again, some resources for you all to go back to your communities so that you can have more conversations around this too. This was an ad that a Canadian campaign actually featured several years ago, right? And that that people didn't have expiration dates, right? And this is from an ageist perspective too of, we're not asking questions on relationships, on sex and sexuality, and there can be a lot of mental health concerns that go along with that too. So breaking down a lot of the stereotypes and myths around it. There is this perception that as people age, they are less sexually active, that they have less interest in sex, that they aren't even engaging in any kind of sexual activities, and that they are having sexual health concerns that maybe make it difficult for them to have sex. So why should we even ask those questions in the first place? But that's not true. We actually have a lot of research that shows us that as people get older and are aging, that they are still very much sexually active. So when we think about individuals, and I want to preface too, we are talking about cisgendered individuals. A lot of the research focuses on these cis heteronormative populations, but I want us to be really mindful, and I will do my best during this presentation to have conversations around those that are in same-sex relationships, polyamorous relationships, and even our trans and non-binary folks as well. So again, like I said, a lot of our research, unfortunately, centers around heteronormative couples and cisgendered individuals. So for cisgendered men, so again, those are signed male at birth that identify as male, ages 70 to 79, 59% of them actually reported still having sex. And usually, again, this is penetrative vaginal penis penetration within the last year. A lot of them are still having intercourse at least twice a month. There's a lot of self-play or masturbation play that is going on. We do see some of those numbers that drop over the age of 80. A lot of that can be just, again, a combination of taboo, maybe fear of disease, medications, isolation, if there's mobility concerns as well. And what about women? Okay, so for cis women, ages 70 to 79, 39% of them actually reported having penetrative sexual activities within the past year. And 6% of them said that they had intercourse at least twice per month, and that they were still masturbating also. Again, over the age of 80, we see those numbers drop for those same reasons that we do with men. The other kind of reality that we see with folks for cis women that are in kind of that 79, even above 80, is that their partner has passed away. and that they have not been able to find another partner, or they don't want to find another partner, or that's just not something that is important to them in their life too. So that's one of the reasons. We do know that statistically too, that men do, their life expectancy is a little bit shorter than women. And that's where that discrepancy of not being as sexually active as we see men for that reason. All right, let's keep going. So when we think about physical changes, right, we talked about we're going to get physical during this presentation. And I'm going to focus, like I said, a lot more on the biology piece of it. What's happening, right? So what are these physical changes and how does it relate to sex and sexuality? So it really isn't the aging that is causing this dysfunction, right? I think that that is we throw this out there as, oh, you're just getting older, that these things are actually happening, but that's not actually true. We see a lot with cardiovascular changes. If we think about arousal and orgasm, you have to have blood flow for that to happen. So maybe it is a high blood pressure medication that you're taking that's causing disruption of that blood flow. We know that cholesterol medications can do this as well. And then even diabetes. Diabetes has a huge cardiovascular impact. And so if those blood vessels aren't working as much as we would want them to, it leads to erection issues and arousal issues as well. What about orthopedic changes? So people who have osteoarthritis or even muscle aches, joint pains, fibromyalgia, anything on that musculoskeletal side of comorbidities, it really leaves range of motion limited, right? So when we're thinking about sexual positions or your back or how you should be propped during sexual encounters, this can lead to avoidance. So maybe you're not able to do the sexual activity that you did before, or you've tried different ways to modify it and it just doesn't feel as good as it once did. So you just kind of avoid that whole piece of it. What about hormonal changes? This is a huge impact too. We know that a lot of, again, cis women that are going through perimenopause and menopause, this happens at age 45 to 55, with the average age of women going through menopause around 51. So those hormonal changes, we have to remember that it's the ovary that's failing for those individuals, and that there is testosterone, estrogen, and progesterone that is made in that ovary. So everybody actually has testosterone too. So for cis men with testicular changes and kind of this andropause, that testosterone is declining as well. Testosterone has a huge impact in how we feel overall. So it's not just libido, but it helps us with energy. It's cardioprotective, helps with muscles, it's bone protective, it's brain protective. All of those things definitely come into play. And we'll talk a little bit more too, as we get into kind of the toolbox of things of how these physical changes are then impacting your ability to engage in certain sexual activities. With menopause, we see genitourinary syndrome of menopause, where a lot of the hormones in those genital tissues are starting to go away, which leaves thinning, dryness. Remember that blood flow that we talked about? We know there's a direct correlation with hormones and blood flow as well. And then again, on the testosterone side of things for cis men, that definitely can impact libido too, but we know that there is also a correlation between erectile function too. And then different medications. We already kind of covered some of them in the high blood pressure or high cholesterol medications that can impact the sexual response cycle. The other types of medications can be anticholinergics, which is what we see for overactive bladder. Everything kind of gets dried out or slows down. So sometimes that can impact the moisture that is occurring in those genital tissues. For us here in the mountains, it is springtime and pollen is out. So those antihistamines and allergy medications can cause dryness in the genitals as well. And then surgeries, whether this is abdominal surgery, pelvic surgery, those that have undergone hysterectomy, whether that means removal of the uterus or just the uterus and the ovaries. If somebody has had bladder surgeries or prolapse surgeries, when we're thinking about men, anything that's going to impact their pelvic health, if there is prostate cancer and there's been radiation to the genitals or to the pelvis, colorectal surgeries can impact this too. So there's a long laundry list. So again, we're just kind of hitting the iceberg, the tip of the iceberg for this. So you heard me say sexual response cycle, right? What in the world is a sexual response cycle? And everybody has one, right? We really didn't realize this until the 1960s and 1970s when we had William Masters and Virginia Johnson that did a lot of research on the sexual response cycle and how bodies are responding. So they found that this is going to be kind of our linear model that we see, and we see it broken down into, again, kind of the cis male and the cis female. So if you can see my cursor here, right, what kind of starts on this is going to be the desire piece of it, right? And we're going to kind of increase here, and we get to a certain level of desire, where then we start to see some arousal, which is this excitement, and that threshold goes up and it meets where the orgasm ability is going to happen. And then as much fun as it would be to stay in a state of orgasmic bliss, right? We have to get back to social activities. And so we have resolution, which is where the body gets back to baseline. When we think about arousal and excitement, this is where a lot of those physical kind of changes come into play. And although I talk a lot about the recipe for orgasm and how that has to happen with surface area, blood flow, and enough stimulation to those genital tissues, we know that orgasm can happen in a multitude of other ways. People can have orgasm sensations with nipple stimulation, even just thinking, right? We know all of these chemical changes are happening in that limbic system of your brain. So there are other factors that definitely can improve that and have orgasmic achievement as well. If we see on the female side of things, kind of very similar. We have the desire, and then we're building up to this excitement and arousal, and then orgasm. The very interesting thing that happens for those that are assigned female at birth is that there's multiple orgasms that can actually happen if you don't let that arousal piece and that stimulation to fall below that threshold. So multiple orgasms can happen. Although you see where this little black line is too right here is that you can sometimes not achieve orgasm and you just sit right under that threshold. And then we have resolution as well. The very interesting thing between these two is what's called a refractory period. We don't see the refractory period here on these graphs, but the refractory period is the time it takes to get from one sexual response cycle to another. For women, there is either little to no refractory period, which is why women are able to be multi-orgasmic on this side. However, for those individuals that are assigned male at birth, you have a refractory period, and it is much more difficult to achieve those multiple orgasms. What is the refractory period, right? So when folks are in their teenage years, early 20s, that refractory period could be 10 seconds, right? You're ready to go again immediately. But what we do see with aging and with medications, that refractory period lengthens, right? And it can lengthen up to hours or even days. So when I talk to a lot of my patients about allowing yourself enough of a recovery is what I tell people, rather than this refractory period. Some people need more of a recovery to rebuild all of those neurochemicals that are happening in the brain again for your body to start this process all over. But we're still learning much more information about this refractory. So I'm excited to see where our research is going. We're seeing an explosion of sexual research that is happening right now. And it is a really exciting time to be in sexual medicine. All right, so I was talking about the sexual response cycle. So we have the William Masters and Virginia Johnson models that we just saw that were more linear, right? Kind of just very kind of straight line, not dynamic. But what we actually have is more of a interactive, and this is Rosemary Basson's sexual response model, and she said that in looking at research that women in particular, those assigned female at birth, tend to have a different sexual response cycle, that there is a lot more involved with it, that it isn't just necessarily this spontaneous sexual desire, that maybe this is a responsive sexual desire, meaning that sex is not top of mind. a lot of times for women. They're multitaskers. They're at the kitchen sink doing dishes, we may be packing lunches, we may be doing the laundry, or there's, thinking about prepping for a brief if we are an attorney, or prepping charts for the next day if you're a medical provider. There's other things that are sometimes top of mind for those folks. However, you can be responsive to a sexual desire or to a sexual advancement if something happens. So say, for example, you're at the kitchen sink, right? You're doing dishes, you're putting things in the dishwasher, and your partner comes up behind you and gives you a hug, starts to kiss your neck. You then start to feel turned on, right? So it isn't that just desire piece that we saw in the other cycle that really leads you to that arousal. Sometimes it's the other way and is flip-flopped. For those that are assigned female at birth. So this is just her interpretation. And I find that this is super helpful in having conversations with my female patients when they are feeling really frustrated that they're not the initiator, right? Or their partner's like, why don't you ever initiate sex? You must not like me. You must not want to be with me, right? And really, it's just giving some background information on why that's the case. And when I pull this graph out and we talk about the different pieces here in this cycle, there's really a light bulb that goes off, which is really exciting to see for those folks. When we start to think about when there's not responsive sexual desire there, when that partner's coming up behind you and making those advances, that you're just like there's no level of excitement that's happening, that's when we figure out, okay, there's some discrepancy here. What is actually happening for us to investigate further and come up with a solution? So you heard me talk a lot about the biopsychosocial pieces to that, right? So it's the biology, this is that physical health, genetic vulnerabilities, drugs, surgeries, medications, all of those things are in this biology piece, right? So we've got the psychological pieces of it. Again, physical health sometimes is in here too, but it's those coping skills, our social skills, how we relate to our family, how is our partner, what is our self-esteem? And then the big one here too is how is our mental health? Right. And then the social cultural side of things too, right, is all that noise that we're hearing from the outside. So from a Hollywood, from social media, from our peers, what were our family values, right, growing up? Those are all those influences. So a lot of times I tell people, I could give you all of the testosterone in the world to try to make this better. But if we're fighting against some mental health or self-esteem, or again, those messages that you had growing up, we're not going to do you any good. It's all of these pieces that have to work together. But again, I focus a lot on that biology side. So what can we do to help support folks that are struggling with sexual health concerns? So we're going to, like I said, talk about the biopsychosocial piece mostly. And a lot of times it's medications. Okay, so we talked about testosterone as being some of that hormonal supportive therapy. Again, about 70% of the time when we replace testosterone and support it with the body, that you'll see some improvement of libido, right? So this is why we can't say that testosterone alone is the sex hormone, right? But testosterone may give you more energy. It may help you to sleep better. It may help you to feel like getting out and moving your body, right? And doing some physical activities. Maybe you now have energy to engage in sexual play, right? So there's roundabout ways that testosterone can help too. Well, what about the estrogen side of things? We do see some studies that show that just replacing estrogen can help cis women, again, those assigned female at birth, especially going through the perimenopause and menopause transitions, and even postmenopause. It definitely shows that it can improve sexual functioning as well. When we think about menopause and the symptoms and the signs that come with menopause, hot flushes, anxiety, depression, sleep disturbances, skin changes, all of those sorts of things. So replacing and supporting the body with estrogen can be really helpful too. And then DHEA is an interesting one. It is actually the precursor to testosterone and estrogen. So when we think about the hormone cascade in our body and how hormones are formed, Things start out with cholesterol, then it turns into DHEA, then it turns into testosterone, and then it turns into estrogen. So talking about this DHEA component can be really helpful also. We find that DHEA is actually really helpful for those cis females that are struggling with vaginal dryness and arousal. There is a medication called Intra-Rosa. Intra-Rosa came out in 2019 specifically for genitourinary syndrome of menopause. So it helps as a suppository and it has DHEA in it so that you can place it vaginally and it will help to rebalance the hormones in that area so that things are plumper, they're juicier, you get more lubrication. The cool thing that we are realizing too with this medication that just was presented at a conference that I was at in March is that DHEA can actually increase nitrous oxide. Why is nitrous oxide important? Well, nitrous oxide is important because, again, it's that hormone chemical that helps to impact vasodilation, so swelling of those blood vessels. So what we have seen with women that are using this suppository, they're not only getting more elasticity, more collagen, more stretch, more plumpiness, more lubrication, but they're actually feeling more aroused at the same time. One of the concerns that I hear from a lot of my female patients is they're having difficulty reaching orgasm, or they may feel like the intensity is not as good as it once was before. And so this product can definitely help with that as well. Now, we know that Viagra came out in 1995. I think it was first on the market. Well, it was approved and then released in 1997, right? So Viagra has been around for a really long time. And we have seen some other medications that have fallen afterwards, like Cialis, Levitra, Stendra, or some other ones as well. What Viagra and Cialis and this whole group of classes of drugs here and how they work is that they are blocking this PDM5 so that you're getting more vasodilation and more blood flow, right? And so this is going to help for folks that are struggling, again, with erections, whether they're having difficulty attaining or maintaining those erections. And so they've been FDA approved for that. They work about 50 to 60% of the time. And I like to use these medications on a daily basis. We have to think about blood flow is happening to the genitals every single day, right? And so we are trying to simulate that same response. What happens is your body is super selective, right? It is a protector of your heart and your brain, those things that have to make you live. When we get to a certain part in life, biology, evolution, right, is saying, okay, we don't necessarily need to have those parts of our bodies working as optimally. So it's going to shunt blood flow other places. And that is one of the things that we see with erectile difficulties, or even, like I said, arousal in those that have vulvas as well. So just a little side note too, if you are an individual that has a penis and you have started to notice that your erections are not as strong as they once were, or you're not able to maintain them as much, and you haven't talked to your provider or you don't have a cardiologist, we know that this is actually a warning sign for larger cardiovascular concerns. So my cardiologists know that anytime I have a patient that comes through and they say, no, I've never been evaluated, this is the first time that this has happened to me, and they're not on any other medications or nothing else is really going on, I'm immediately referring them to that cardiologist so we can do a full workup and evaluation on their heart and their other blood vessels. Remember, I said I am a preventer. I like to prevent things from happening or help to support them early on rather than waiting till they're already a problem. It's harder sometimes to back up and try to promote the healthiness and the impact of that disease process. So I like to start nice and early and have those conversations, like I said, early and often. So you can do daily Cialis, 5 milligrams. I think works really well. And you can do that sometimes in combination with Viagra, but I always say, talk to your healthcare provider to find out what's going to be the best for you. We can also do these medications for those that are assigned female at birth. It's off label. And again, this would be something to talk to your healthcare provider, but I have found it to be super successful in a lot of my, again, cis females that are struggling with arousal and sometimes reaching orgasm. We don't necessarily need to go up to that level that we would for cis men. but it definitely can work too. And then we have actually some non-hormonal methods that have come out too. Addyi is a non-hormonal medication that came out in 2015, specifically for women with low libido. It works in the prefrontal cortex of the brain to help to decrease inhibition of sexual functioning and rise excitation. So you're going to have more thoughts, feelings, desires that are associated with sexual health. And that's a pill that you take every day. And then we have Aleece, which came out around the same time also. And this is a sub-Q injector that you use as needed to help to promote libido as well. And remember, I always tell people, please consult your healthcare provider to find out which one is the best for you. There are some contraindications and cautions to these medications that are out here. But again, everybody is individual. That's what I really love about my approach in medicine, is that there's not one algorithm that I use and I put on everybody. We try so hard in medicine to make the algorithm fit the patient, or patient fit the algorithm, rather than the algorithm actually fit the patient. So I individualize a lot of my treatments and really talk to a lot of people about your goals. And that's one of the things that I like to talk to patients about too, is what is your goals? What are your hopes? What are your wishes? What do you want to see from this experience? What do you want to get out of it? And we talk about, level of expectations and what would be realistic there. The other important thing on the biology side is physical therapy. We don't hear enough about pelvic floor physical therapy. We have pelvic floor muscles that act as a basin in your pelvis to help to support all of those pelvic organs. They have sexual function too. They actually contract during arousal and then super contract when you hit orgasm. For some folks that have had stenosis or stiffening of the vagina, or maybe even the anal canal, we can use dilators to help with that as well. We have to remember that those pelvic floor muscles are part of your core too, okay? And that core, what I tell people, sometimes includes nipples to knees, all right? So it means it's your abdominals, it's your lower back, it's your hips, it's your adductors, your abductors, your thighs, how that's all working together. So what physical therapy can do is help you work on your hips and lower back too. The beauty of all of this, also to be said too, is that this is going to help with your balance and coordination, so that when you're wanting to try different sexual positions too, that we're always worried about falls, right? Or what this actually looks like. So this is going to help you with that balance and coordination, and then to be able to do those functional movements as well. Okay, so what's in our toolbox? This is going to be really important. I could talk about this whole toolbox for a day. So the fact that I have just a few minutes to talk about it, but I want to start to get you all thinking about, there are things that are out there. When we're thinking about products and anything that's going to be insertive or going into the body, we want to make sure that it's body safe, okay? So when we talked about those dilators here, it's called Intimate Rose is the dilator set. These are nice and soft, silicone. They're going to be body safe. Here is a picture over here of some other toys that you all can use when it comes to sexual enhancements and in sexual aids. So like this one right here is a kind of a standard vibrator. This one here too is definitely going to be a standard vibrator for you. And you don't have to be a vulva owner to use a vibrator. Vibrators are used by everybody, and it's actually the #1 sexual enhancement aid that we have out there. We know that with diabetes or blood loss, with like blood pressure medications, sensation is going to be a big factor of why people are not achieving orgasm. So the cool thing about vibrators is that they're going to add a level of sensation for you to get you increased sensitivity and arousal and orgasm. So these are just, again, like some products. This one's called a WeVibe. This gets inserted into the vagina, and this part is on the outside to have direct clitoral stimulation on the outside. This one here is an anal plug. Some men, as they get a little bit older and have had some disease process of enlarged prostates or stiffness of the prostate, prostatitis, they need some extra stimulation. And so direct prostate stimulation can be helpful too. That's this one also. I like this product. It's called Enjoy for the reason that it's stainless steel. Right now I'm thinking about the cleaning process, right, of these sexual aids. So stainless steel can be cleaned really well. You can boil it. With a lot of these other products, I talk a lot about using warm water and an antibacterial soap like Dial, but then you got to let them sit out so that they dry thoroughly before you put them away. These two products right here are by Liberator. This is a nice blanket, like a sheet. A lot of times I have people that may have some urinary leakage during sexual activity or some other bodily fluids, and they want to make sure that cleanup can be really easy. So this is really nice to help. It's like an absorbent sheet without having it leak onto your bed or a couch or the floor. So you're able to put this down there too. Liberator also makes some amazing furniture and props. Okay. When we think about what the body needs to, especially if there's some mobility issues, we want to be able to support that body as much as we can, whether it's lower back support, hip support, a chair, anything like that's going to be really important. So Liberator's a great source for products. And you see how this one has a zipper here. You can take this cover off and wash it, which I really love. If I'm going to put you up here, draw your attention to the upper right-hand corner, this is what we call like a sex stool. So for people that are having issues with strength or holding themselves up or whatever it might be, their partner can lay under here and you put this stool over top of them. It's got some great handles here. So again, balance and coordination for stability. And then you can see here that there's, it's almost like an elastic material. So it has a little bounce to it, almost like a trampoline. So that when you are doing any kind of thrusting or up and down motion, that works out really, really well too. Another product is a vacuum assisted device here that we can see that fits over the penis, has a penile constriction ring too. That's going to help to bring blood flow into those penile structures as well to help attain and maintain that erection. The last thing here I want to talk about is lubricants and moisturizers. Remember, we talked about dryness that can happen. Lubricants are fantastic. Lubricants are non-hormonal forms that can be used at any time of during sexual activity. Uberlube and Desert Harvest are one of my favorite two products that you can use. Uberlube is going to be a silicone lubricant. Now I'm going to tell you, Uberlube is super slippery. So you got to be really careful, especially if you're going to use this in the bathroom or any place that has like a tile floor, or if you decide to have some sexy time in the shower. I tend to not recommend that because again, of how slippery. So if it gets on the floor, I'm always worried about somebody falling and hurting themselves. Aloe vera or Desert Harvest has aloe vera in it. And this one is very satiny, very soft, and can be used to during sexual activity. You can also use the Aloe Glide, or I guess either of these products, if you wanted to start with some foreplay and massage. These are just great to have. They're not going to stain sheets, anything like that. The two moisturizers that I want to draw your attention to is this Reverie and Hyalogen. These are two great products, again, non-hormonal, that have hyaluronic acid. We have found that hyaluronic acid helps to bring moisture and keep moisture in tissues. So moisturizers are going to be very similar to what you use like on your skin, like for lotion to help keep moisture in them also. This is what we're going to use in the genitals and those vulvovaginal tissues as well. Hyalogen also makes a suppository. They also make a gel. So if you're having some dryness or irritation to the vulva, that can work out really well here too. When we think about moisturizers and lubricants, I have 3 rules, okay? No fragrances, no glycerin, and no parabens, okay? So no fragrances, we don't need to smell like rain and roses and everything else. That can be really irritating to the genitals. The second one, which is glycerin's like a sugar. So anybody that has increased yeast infections or any kind of vaginal infections, yeast loves it. We know that glycerin too can cause a lot of irritation to the genitals, so we want to avoid that. And that third one is going to be parabens. Parabens are typically those preserving agents that we see in products that are going to keep it on the shelf, right? So anything that you're seeing kind of in, Target, Walmart, down that hygiene aisle, right? A lot of those products are going to have fragrances and glycerin. Astroglide and KY Jelly are the two that I really have people avoid. Okay. If they work for you and you're not having any issues, don't worry about it. Don't rock the boat. That's okay. But if you are having issues or having concerns of finding a lubricant that works for you, I really recommend kind of the Uberlube or the Desert Harvest products. Okay, so I wanted to touch just a little bit, thinking outside that biology. Therapy, I'm a huge believer in therapy. Meditation is really great, and using mindfulness too. Lori Brotto, who's a Canadian sex researcher, has a book called Better Sex Through Mindfulness. It's a short book. She has a workbook that goes with it, and it's great to do for yourself or for you as a partner. And then what are the health benefits, right? We talk a lot about sex and sexuality and looking at it from a holistic point. How is this going to improve my health overall? The interesting thing, like I said, is that, the World Health Organization talks a lot about the importance of sexual health as being part of your overall health and well-being. And when we think about activities of daily living, which is really important for your occupational therapist or for your physical therapist, we're taking a look at these things as well. So these are all major health benefits to engaging in any kind of sexual activity. Remember, I tell my patients that there's no hierarchy in terms of sexual activities. They're all sitting at the same table together, and you're just inviting which sexual activity to the table at certain times, right? So penis and vagina penetration may not always happen. You may have a partner that has the same genitals as you, and you're not engaging in those types of, again, heteronormative sexual behaviors. Or maybe it doesn't feel good anymore and you want to explore different things. One of the things that I find with my folks that are like over the age of 50 is that there's this newfound love for their bodies sometimes, and they get really excited of having this conversation and really opening up their repertoire in different sexual activities that, again, are bringing lots of pleasure and joy into their life. So again, you can see this whole long list here, right? There's so many benefits. We need to be writing prescriptions, right, for sex and sexual health out there. All right, so I know that, again, that was just wetting your whistle with so much of the information that is actually out there, but I really want to make sure that we are focusing on you and what your questions and concerns are. But I wanted to make sure that you all saw this too, right? Remember that you are worthy of amazing sexual health, okay? Write that on a sticky note, put it somewhere where you see it, right? Put that up there. I'm a big believer too in mantras and quotes and inspiration. So thank you so much.
Whoa. You weren't kidding, Aleece. You had a lot of content. Wow,
I know,
awesome.
yes.
Yeah, that was amazing. And people stayed with us because it was so rich and so valuable. I'm going to bringing up some of the questions we
Let's
heard.
do,
I need to
yeah,
make a quick disclaimer because AARP can't endorse a product through
yes.
our nonprofit. So those endorsements were, by Dr. Fosnight, and we can take those as hers, but not endorsements through AARP. And we appreciate, the really down to earth suggestions that you provided. So there's some great questions that have
Yeah.
been lining up. Okay, so a few people had some questions about one of the medications, and I think it was Interosa or
Yes.
something. Okay,
Mhm.
so they wanted you to spell that.
Absolutely. Yes. So intra rosa, INTRAROSA, intra rosa. And I'm going to put that in the chat too, so everybody has that as well. I think I can put it everyone. Yeah. And again, I am not, I don't endorse any products or have any affiliations with these products as well. These are what I see clinically and what I see work really well. Mhm.
Yeah,
Yeah.
great. And, I get that that is of great value because it's hard to weed through all of the
Yes.
information to folks. Okay, so that was an important one. Another really great question. You talked about pelvic rehab skills for female body people.
Yes.
And I didn't know the balance benefits of that.
Oh,
That was
yes.
enlightening. But for men, are there
Yes.
pelvic rehab exercises for men?
Yes, absolutely. So I tend to see for those assigned female at birth that those pelvic floor muscles can be a little bit more on the weaker side. And on the assigned male at birth, they're more tight, right? And I always tell people tight muscles do not equal strong muscles. So think about your
Mm.
shoulders, okay? Tight, right? If they were nice and tight up here, right? You can't do and reach and do the things that you want to. But when they're nice and relaxed, but strong, they're able to engage when you need them to work and to reach up for something. So the exercises that I usually recommend for, again, male-bodied individuals are going to be more stretches and relaxation and belly breathing. We talk a lot about the diaphragm and the pelvic floor as like a can, right? The top of the can is going to be your diaphragm and the bottom part is your pelvic floor. And so deep belly breathing where you're engaging that diaphragm and it's helping to open up and lower, boom, your pelvic floor does the exact same thing. So it helps to really open that area up. And those muscles, when they're so tight like this, right, you want to be able to open them up. So again, that you can have that strength and that ability. When you have tight muscles, it limits the nerve sensation and the blood flow, right? So it's clamping down on both of that. So even if you're super aroused and super into the moment and your body's like, yes, this is what we want to do, that arousal still may not happen or the sensation because those muscles are too tight. When they're too tight also, you can't have engagement of those pelvic floor with contractions during orgasm. So the intensity may not feel as strong as it once was. Same thing for weak pelvic floor muscles. They're almost too weak to be able to engage. And so you don't get that strength and intensity as well. So yes, and I would say most pelvic floor physical therapists work with all genders. So
there's a whole world of muscle strengthening out there for us that we
and
may not.
insurance should cover that too, which is really great. I know that's a question we get a lot of times too is, does my insurance cover this and what's going on? But yes, their pelvic PT is greatly underutilized.
Medicare? Do you know if Medicare covers pelvic PT?
They
too?
should.
Yeah.
Yep.
Cool.
Yep.
Okay. The name of the workbook mentioned, I think Chantel got that,
Yes.
but
Yeah.
you can repeat it.
Yeah. Better Sex Through Mindfulness by Lori Brotto. And I'll put it in the chat too.
Sweet. And that's a nice segue to our presentation next week on mindfulness as well. Okay. And is testosterone prescribed to both male and female bodied or people who identify as men and women?
Yep, absolutely. So we only have FDA approved formulations on the market for cis men. So for assigned male at birth individuals. We do not have testosterone out there for assigned female at birth individuals. So we just use it off label. When we think about testosterone is one of my favorite. I love hormones. I don't think I talked about this either, but I've been a PA for 12 years, but I've been doing gender affirming healthcare for almost 10 years now. And so thinking about hormones and how much hormonal foundation is for everybody and how it can make a huge difference. I've seen it clinically so many times. So I'm a believer. So with testosterone, when we think about it for, again, our female-bodied individuals, it's actually 1/10 of the dose of what those that are male-bodied individuals would actually have. So it's hard for us to do like 1/10 of a packet or 1/10 of a pump, if it's in a pump gel. So I do compounding. Unfortunately, that means that you have to pay for that out of pocket, but it works really well for those individuals. And a little bit definitely goes a long way.
Great. Okay. Where is the best? And again, this we can't endorse, but this is a question you can
Yes.
give your opinion on. Where is the best place to buy sex toys?
Oh, goodness. So if you are here in Asheville, I'm a big fan of Vavavoom. They have top-notch folks that are sex positive, body positive, all of that. Lilo is one of the companies that I love. They're all body safe, silicone, rechargeable, and they have a variety of different ones. Crave is going to be my next one, and I can put these into the chat too. So Crave, CRAVE. I like their products because they are stainless steel. So again, I know I'm all about the cleanliness, right? And stainless steel actually has a warming. So some people like that warming sensation. They have different vibrators that have different intensities, different rhythms that go on it. Those would be those two. I feel like I'm blanking on one. I caution with Adam and Eve, which is a big, sex toy company that you can get online. The thing about, they do sell Lilo, they do sell Crave. Again, it's more of the material. So that's what I usually tell people. A hard plastic is going to be good. Dame was the other one. I forgot. Dame is the other organization. So Lilo, Crave, and Dame. Those are my two top ones. But Adam and Eve will definitely carry those products as well. But we want it to be a hard medical plastic. We want it to be silicone, stainless steel, or glass are the ones that we talk about. If you go to open up a product and it smells like you just opened up a shower curtain, it's that rubber, it's that PVC. The problem with those products is that they're really porous. So when you go to use them, right, you're using them on your body, and that bacteria that's on your body gets into that product, and then you can't clean it because it's just stuck in those pores. So I worry about infection. Plus, it's a chemical, it's seeping chemicals, and that can get into your body. The unfortunate thing is we don't have like an FDA organization for sex toys. So anybody can make anything with any material that they want to.
Wow.
So I'm super protective of my patients and what products that they use. So I usually say just avoid rubber if you can. And sometimes it's really difficult. But, and I know too, when I talk to my patients that are having like dexterity issues, sometimes it's really nice to get a bigger device rather than the smaller ones, so that you have more range of motion. You can move it where you want to. It has a bigger surface area. Sometimes that's what folks need as well, but everybody is different. So if you can go to a store, that's great, because then you can actually touch it, feel it. How do I like it? Does it feel okay in my hand? You obviously can't use it on your genitals, but you can at least see, do I feel like I like this product? And I know that it is sometimes financially restrictive for some folks, because the rechargeable ones or these medical grade ones can be a little bit more expensive, but a lot of times you use it and they're good for like 20 years. So.
Great. Okay. Well, there's a couple more questions here.
Yes,
We'll get to
absolutely.
as many as we can in the
Yes.
next 5 minutes. Okay, so thank you for the great information. I run a group for older LGBTQ adults,
Yes.
and we see clinicians not understanding the difference in same-sex relationships versus heteronormative relationships, and potentially disease states more prevalent in the community. Assuming that the constituent has been honest about their sexuality, how is it best to open a dialogue with your practitioner? Any
Mhm.
suggestions on that?
Yeah, I think saying that the type of partners that I engage in sexual activity have the same genitals that I do, and I want to know more information about safe sex practices, what types of sex that I can do, what's safe. And so opening up that and just saying, this is how I identify, these are the partners that I engage in. It can be really difficult to open up those conversations. So I usually tell people, practice with your partner, practice with a friend. The more that you say it, the more normalized it becomes for you to have those conversations. I think I say vagina, penis, clitoris, orgasm every single day. And it's like my vocabulary now, but I've said it so often. But I get it's really difficult to bring that up to a provider that you may not be feeling as comfortable with. You can always like talk to their medical assistant or their nurse and say, I have some sexual questions. How does your provider handle that? Do you know? Because a good MA knows their provider. So that can be another kind of gateway to see. If you go to iswish.org or NAMS or SMSNA, there'll be a locate provider on there. So you can find providers in your area that have that sexual health knowledge. So if you needed to talk to a provider about that, it feels a little bit more comfortable, that you can do that too. I'm going to put those in the chat real quick.
Cool. So, as long as we're on the topic of providers, does your practice accept Medicare?
We do not. And I'm really sad about that. And I really wish that we were able to do that, unfortunately, with reimbursements and things like that. And on a medical side, we could talk about this for a long time. However, we offer self-pay options for our Medicare and Medicaid patients so that they can still be seen. And what I try to do for those folks is we optimize those appointments so we get as much in there as possible. And then what I do is I follow up through the portal, we do phone calls. So again, we're minimizing what those follow-ups look like, so the cost is down too.
Okay, a couple questions in
Yes.
Q&A and in chat. So folks, we might take this 5 minutes over, 11:05. Stay with us if you can, go if you need to, but I don't want people to leave here with their questions unanswered if possible. Can women have a narrow vagina? If so, what does this mean sexually? Is it the same as tight muscles?
No, it is not. So narrow vaginas happen secondary to loss of elasticity. When we think about it during the reproductive years, when estrogen and testosterone are flowing through those genital tissues, you're going to have what are called rugae. So you have mountains of vaginal tissue that go up and down. They're hundreds of layers thick. Okay, so that it adds as a cushion. It helps to expand so that things can go into the vagina, things can come out of the vagina. It causes blood vessel development so that you're getting what's called transudation, which is lubrication. So it's the water and the moisture that's coming from blood vessels and seeping into the vaginal walls and into the vagina to help with, again, moisture and lubrication. So all of that, it's plump and juicy. It's what I tell my patients all the time, right? So what happens, again, like through menopause, through medications, through chemotherapy, through radiation, those layers, hundreds of layers of cells start to slough off. And now you're left with like 2 or 3 layers. And so rather than having these big mountains, it's desert. It's flat. There's no stretch. There's no elasticity. And what happens is then it narrows. Okay. So it makes it really difficult for anything to go into that vagina. There's just no stretch. Tightness of those tight muscles, or more of those pelvic floor muscles, again, that are acting like a basin. Those tight muscles, again, just can be limiting on anything being receptive into those tissues as well. Can you have both? Absolutely. And sometimes the dryness or the narrowing of the vagina causes what we call reactive pelvic floors. So then that now you have 2 things that are going on that are limiting, and that can cause pain with sex, dryness, friction, bleeding, all of that irritation.
That makes sense. Okay. Thank you. On that topic, what is the daily pill to help with female libido?
Gotcha. Addie,
Okay.
ADDYI, yes. And so it is approved for premenopausal women here in the United States, but I use it, again, off-label for my menopause and postmenopausal women. It is approved for postmenopause women in Canada. So,
Okay. Good to know.
Yep.
A couple questions about prostate. So I'm going to
Yes.
pair them together about suggestions do you have after sex, after prostate surgery or cancer? And then what about weakness or some incontinence following radiation of the prostate?
Yep, absolutely. So I'm going to kind of address that first one. So any like prostate surgeries that may happen, I often think people are talking about an enlarged prostate and like a TURP procedure, a TURP, which is a transurethral resection of the prostate. So when the prostate gets large, it narrows the urethra. And so urine can't come out as much as we want to. So we go through the urethra and open that area up through a variety of reasons. That can cause some incontinence, because if you get into any of the sphincters, that's going to cause some discomfort. What they don't tell you often is that your ejaculatory ducts are right there too, and they can get occluded, or instead of angling down now to come out the urethra, they angle at each other or up into the bladder. So sometimes you may have decreased volume of ejaculate. You may have pain with ejaculation. Typically, we're not seeing any blood flow involvement. We're not messing with that at all. Sometimes what happens is it just so happens in a coincidence that they're now having some erection issues afterwards, but it could be related to those pelvic floor muscles. When you have radiation to that prostate, things get stiff. Okay. So stenosis of those blood vessels, but also stenosis and stiffening of those pelvic floor muscles. So it may not be weakness of the pelvic floor muscle that's going on. It could be tightness. Tightness can cause urinary incontinence also, right? We forget that can happen. So being evaluated by a pelvic floor physical therapist is going to be key to understanding what's happening with your body and why the things are happening. And then they come up with an individual treatment plan.
Wow. We just want you forever, Aleece.
I
This
know.
is so good. So I'm going to ask just one more question, and then we're going to have to go, and I'm going to refer folks to their providers for their additional questions. So I hit menopause on June 1st. I'm 53. Does sex help with hormone headaches?
It can, right? So when we think about the neurochemical process and what is released through it, especially with orgasm, so norepinephrine, dopamine, sometimes testosterone is going to be stimulated through that, but it may not always be the best answer. So I definitely would talk to a provider in your area to dig a little bit deeper at what's happening. You actually may need to have some hormone replacement. And we know through the North American Menopause Society that hormone replacement is pretty safe for most individuals. We got scared back in 2002, right, with this Women's Health Initiative, but we have so much rich knowledge now that we've learned from that again, it's pretty safe for, again, most people.
Awesome. Well, you really have been a gift to everyone here today, Aleece, and
Oh,
thank you for being with us today on behalf of both AARP and my colleagues at UNC Greensboro, and everyone for joining us. Thank you for the gift of your time, presence, and knowledge. We will be following up with an email with a survey. We'd like to hear what you think and give us feedback, and also recordings for both this session and last session. I want to remind you that we finish out the series next week with a session with Macy Day, Haikomi, psychotherapist on mindfulness. We'd like this to be a beginning, not an end, to our work in sexual health in the Mountain Region, North Carolina with AARP. So we hope to continue to work with you, Aleece, and each of you for joining us. So thank you all, and we will say goodbye for now.
thank you.
Thank you.